while I was first year student of BDS in King George's Medical College. Dr. Azad has served as a senior advisor of dental and maxillofacial surgery in Armed Forces Medical Service. After his voluntary retirement, he worked as a senior consultant in many reputed healthcare centers such as Apollo Group of Hospital and Nizam Institute of Health Sciences at Hyderabad before joining Globe as honorary clinical director and chief consultant of maxillofacial surgery and implantology. His special interests and expertise is in oral and maxillofacial surgery, implantology, endodontics, and cosmetic dentistry. Currently, he is honorary director and worked as a clinical director between 2015 to 2021. He is a recipient of Professor S.S. Khera Award for outstanding contribution in oral and maxillofacial surgery in 1998 by Association of Oral and Maxillofacial Surgeon. He is a Lifetime Achievement Award by Oral and Maxillofacial Telangana and Andhra chapter in 2019. He is an honorary fellow of oral laser application, honorary fellow of oral and implantology, India and Vienna, facial aesthetic and cosmetology. Above all, he was chosen as a leading health professional of the world for his great contribution in the field of dentistry and maxillofacial surgery by Internal Biographic Center, Cambridge, in year 2011. He is a dear friend and is a guide and a good mentor. With all these words, I welcome Dr. Mahendra Azad as a chief guest for this webinar, which is on the way. Over to you.
Thanks, Adendra, for such a long introduction that's not required. I welcome all of you, and I hope you'll be greatly benefited. Today, implantology, as all of us know, has come to stay in our everyday practice in dentistry, and knowing about the materials, biomaterials, what to select, when to select, where to give, what is needed is very important. And I'm sure Dr. Gandhi will be enlightening you, and you all will be benefited. So I request Dr. Gandhi to come up with this presentation. Thank you.
Thank you so much, sir. Now I would like to invite our co-convener, Dr. Sarvraj Kohli, sir, who is graduated from SP Dental College, Wardha. He did his master in discipline of orthodontic and dentofacial orthopedic in 2010 from Savitha Dental College and Hospital, Chennai. He underwent training in the Tweed Merrifield Directional Force Technology at Arizona, United States. He is currently consultant orthodontist at Jabalpur Hospital and Research Center. So now I would like to invite Dr. Sarvraj Kohli, sir, to introduce our speaker and panelist.
Good evening. I deem it my distinct privilege to introduce the two panelists for today, Dr. Rajkumar sir and Dr. Shadab Mohammed sir, along with the speaker, Dr. Yazad Gandhi. At the beginning, we will see a brief introduction for Dr. B. Rajkumar. Dr. B. Rajkumar is a highly accomplished dental practitioner with a wealth of expertise in his field. He holds both a master's and a PhD degree in implant training in Heidelberg, Germany in '95, and was the former dean of Babu Banarsi Das College of Dental Sciences at Lucknow. He has an extensive experience in education and training. Currently, he serves as the director for dental at Medicis, an e-learning content provider for MBBS, PDS, nursing, pharmacology, and physiotherapy. He has also trained postgraduate students in conservative and endodontic department as well as dental implants, and is considered an Indian pioneer for the magnetic mallet as an adjunct for the placement of implants. Furthermore, he has used SIAM's BCT study in implants, demonstrating his proficiency with advanced dental technologies. Our second panelist of the day, Professor Shadab Mohabbat. Sir needs actually no introduction. His word is an
835
introduction enough. He
3067
was awarded the Padma
9589.
Shri from the Government of India in 2019. He's also a UP Ratan awardee. He is currently the professor and head of department at the Department of Oral and Maxillofacial Surgery, as well as the ex-dean of the FDS at King George's Medical University, Lucknow. He has a teaching experience of over 35 years and has received the FFDS RCSI from Ireland, the FDS RCPS from Glasgow, UK, the FDS RCPS from Glasgow, the United Kingdom. He is the fellow of the National Academy of Medical Sciences. He has been awarded the WHO Fellowship for Advanced Training in Oral and in Maxillofacial University Surgery at the University Hospital at Zurich. He was the TC White Fellowship awardee. He also was awarded with the AO Fellowship and is a fellow of the Perry-Befauchard Academy, as well as the fellow of the International College of Dentists and the fellow of the International Congress of Oral Implantologists. He is a Rashtriya Chikitsa Seva Ratna Samman awardee, the UP Ratan awardee, a Nagrik Gaurav awardee, the Awadh Sammelan by Samagra Seva Sansthan. And he's also been awarded a Scroll of Honor for exceptional professionalism towards dental sciences by Jamia Millia Islamia University, New Delhi. He's been the governing body member of the Banaras Hindu University and is a member of the Board of Studies at Aligarh University. He's also on the expert selection committee at AMU Aligarh, UPPSC, and Wardha University, Nagpur. He is the Vice Dean of Dental Research in KGMC. He holds his life membership in the British Association of Oral and Maxillofacial Surgery and is a life member of the IADR. He's also a member of the National Academy of Medical Sciences. He is the faculty for AO International. He's also an executive council member of the King George's Medical University, Lucknow. He has been invited as a guest speaker and faculty at several international and national conferences and has also conducted training programs across the world. He's also been the examiner and paper setter for undergraduate, postgraduate, and PhD courses, and is also be keen in social service and in giving back to the community. Our speaker for the first webinar is Dr. Yazad Gandhi. Dr. Yazad Gandhi is an oral and maxillofacial surgeon. He's practicing at Bombay. He has had the privilege of being training under Dr. B. Wilfred Scaly, who was the director of maxillofacial surgery at Freiburg, and under Dr. Karl Kahnberg, the director of the maxillofacial surgery at Gothenburg. He was also trained in endoscopic sinus surgery at Nine Wells Hospital, Dundee, and Blackpool, Victoria Teaching Hospital at Manchester. Dr. Gandhi is the fellow and registered speaker for ITI. He is a fellow of the International College of Dentists and a fellow of the International Congress of Oral Implantologists. He remains on board as a reviewer for the JOMS, the National Journal for Maxillofacial Surgery, and is the section editor for the Journal of Oral Biology and Craniofacial Research. He holds a membership to the European Association for Osseointegration. He has been a recipient of the Jinwala Oration Award for implant-related heart tissue regeneration and is a key opinion leader for the APAC region for BioHorizons, Camlog, Metsi, and Gislish. He has conducted numerous VCD programs and workshops related to implant surgery and prosthetics, both on the domestic circuit and the international circuit. He has mentored implant training programs for nurturing young clinicians. He is also the director of Fusion Education, an organization that conducts CD courses for dental surgeons. He has several national and international publications to his credit. Dr. Gandhi maintains a specialty practice at a private facility in Mumbai with an attachment to a multi-specialty hospital. Dr. Misbah, I think we can ask Dr. Gandhi to begin his lecture now.
Yes, sir.
Thank
Yeah,
you.
sure.
So, good evening, everyone. I hope I'm audible.
Yes, sir, you are audible.
Okay. So, thank you for this invite to this webinar. It's actually an honor seeing that so many of the people who are here have been my past mentors. They have actually held our finger and taught us how to walk in the dental arena. So let's begin without further delay. Today I'll be speaking on biomaterial selection. There's a lot of confusion in the market today when people talk of what bone graft to use for implants. If you use a bone graft for implant, when should you re-enter with the fixture, or when you should re-enter with your prosthetics. So I'll try and clear the air on this. This is just this disclaimer that some of the products that you see here will be from a couple of companies where I am a KOL, but that does not necessarily mean that I will not be speaking on the science behind it. Let's talk where grafting actually started. It's an interesting little trivia here that I'm putting forth. In 1600s, there was a Dutch doctor who performed the bone grafting operation on a soldier with a damaged skull. He actually took out a piece of dog bone and he implanted it. In those days, the church was very strict. Both the soldier and the doctor was excommunicated because the church considered that the soldier became part of a dog, and animals were not allowed in the church. So when the doctor attempted to remove that bone graft, he discovered that the bone had healed so well that it was difficult to discern that what is the soldier's bone and what was the grafted bone. So that, in short, is the trivia of where autogenous grafts actually started in the world. And there has been more than 400 years of history of bone grafting. We, at that point of time, had just about anecdotal evidence. Peer acceptance was a big issue. The techniques were limited. Then we had evolution by way of materials, we had evolution by way of science, technology improved, clinical research improved. And this is where we are today, where and this is the great man. I had the privilege of working under him for 2 weeks. And believe you me, those 2 weeks changed my life, the way I look at implants and the way I look at bone grafts and the way I look at fixtures, as he used to call them, at the University of Gothenburg, the Brenemark Center. And he is the person responsible why we are actually discussing bone grafts around implants today. So we have to control our outcome. Look at these two cases. Both of these have a couple of implants in the aesthetic zone. Now you need to ask yourself that both these are young ladies, one in their 40s, one in their 30s. Now, is this what we expect when we talk of fixtures in the aesthetic zone? Obviously not. If the one on the left of the screen is sent to you for correction, we all understand that the fixtures have been placed in the wrong 3D envelope. So no amount of graft, hard tissue or soft tissue is going to give you a decent result over here. So we need to control our outcome right from the start. So when we say control our outcome, we need to know how it's done. We need to know what is to be done, and we need to know why it should be done. Now, we always knew what is done. You need to put in an implant, you need to put in a crown. You know when it's done, obviously when you lose a tooth. Now what we are understanding is different ways of how to go about doing it, and why to do the different techniques and why not to do the older techniques is what we are beginning to understand by way of research. So let's look at the indications of bone augmentation. When would you look at picking up a bone graft? When you want to augment a socket. When you want to augment the ridge, be it in the vertical dimension, be it in the horizontal dimension, when you want to augment the sinus in the posterior maxilla, whether you want to go in with the lateral approach or the transcrestal approach, or even delayed peri-implant augmentation. Once the fixtures have been in use for a couple of years, you begin to lose hard and soft tissue around them. So decision-making entirely depends on defect morphology, what you need the bone graft for, when you are planning to enter with your fixture, what is the age of the patient, what is the expected longevity. And when we say that decision-making depends on the defect morphology, so the morphology also relates to your surgical skill sets. There are certain defects which are intra-bony, which are very well contained, which don't require to elaborate a surgical skill set, whereas there are defects which are extra-bony, which are completely vertical, or maybe a combination of vectors which are in deficit. And they definitely need advanced level of surgical skill sets to counter them. So the timing of bone grafts can be broadly divided into immediate or simultaneous with the fixture placement, and delayed or staged, wherein you place your graft first and then you return later and place your implant. So we need to again ask ourselves a question: does the timing affect the choice of material? Why does it do so? And when would you place your fixture? Obviously, the timing definitely affects the choice of material, because before we place our fixture, we want our bone to have turned over decently into de novo bone. Why do we need to augment? Why not just place an implant? So we all understand that when we lose a tooth, we lose the bundle bone, we lose the PDL, we lose part of the vascularity, bone begins to sink in. So we may need to augment prior to the implant placement. We may need to augment alongside implant placement. We may need to augment peri-implant defects. What influences the success of a graft? There are a couple of points which you need to keep in mind before we choose the graft. The regenerative potential of the recipient site, which goes hand in hand with the defect size and the morphology. Then the patient's comorbidity, the expected longevity of your rehab, as we discussed earlier, and the predisposition towards periodontal or peri-implant diseases, which is a very innate factor which is inherently there in some individuals and which needs to be countered carefully. Classification of biomaterials can be done broadly by way of physical form of the biomaterial presented to you, or the type of the biomaterial presented to you. So when you talk of the physical form of the biomaterial, it determines the applicability of the area of applicability, the adaptability, the ease of use of the material, the stability of the material, the need for a carrier for the material, the resistance to forces of musculature, forces of mastication, and the need for a barrier. If we pick up a corticocancellous block, obviously I would not necessarily go ahead and use a barrier, but if I use a particulate graft, I would obviously suggest using a barrier. And then come to the biomaterial type, which in turn determines your turnover time, your costs, your indication. And in certain parts of the world, there is a definite religious bias when we come to certain animal source biomaterials. So let's look at block grafts versus particulate grafts. Now here, you will interestingly see that we've fixated a corticocancellous block taken from the symphyseal region on the left of your screen. But at the same time, you also see we are covering it with a collagenous resorbable barrier. Why? Because we have also tried to ramp out the sharp edges of the graft with particulate graft. Remember, wherever you use a particulate biomaterial, you will need a barrier to keep the fibroblasts out. When you look at the properties of biomaterials, there are three basic properties which we have to remember. One is osteogenic potential, wherein the graft itself supplies viable osteoblasts, osteoinductive potential. It stimulates the mesenchymal cells to differentiate into your osteoblasts, which in turn lay down the bone, and osteoconductive, where it acts basically as a scaffold. So when we talk of osteogenic, osteoinductive potential, basically we are only looking at an autogenous bone. We are only looking at autografts. There is very, very little evidence to prove that demineralized freeze-dried allografts have some amount of osteoinductive potential, because all of the others, which are allografts, xenografts, and alloplasts, they basically rely on osteoconductive potential. This is a radiograph which I had recently shared on social media. Scans which are at 10 years. Both these fixtures have been placed by me. Now, obviously, let me say it at the outset that I was not out of my mind to place a fixture on the left side out of the envelope of bone. When I placed it, there was bone there. And this is what we have to remember, that when we have 1.5 millimeters of bone at the facial of your fixture the day you place it, friends, it is not enough to last out 9 to 10 years. It will disappear, because we all understand vascularity plays a major role. And on the right of your screen, you see a scan wherein we placed a fixture, we placed contour graft, using some amount of layered xenograft at the outer. So you see beautiful bone hanging around at 10 years. So we have to understand how to use our biomaterials. When we talk of particulate biomaterials, you have allografts, you have autogenous bone collected by way of scrapers, you have animal bone xenografts, which may be bovine, which may be porcine, you have biologic modifiers. When you talk of block grafts, you can have your autogenous corticocancellous bone, you can have just a cortical plate by way of the Curie technique, you can have an allogenic block. You can use biologic modifiers again to make a particulate layered block, or you have xenogenic blocks nowadays with added os and collagen by way of 10% collagen, which improves the handling capacity of the block. Let's take them one by one. Autogenous bone, your intraoral harvest sites are typically the maxillary tuberosity or the palate, the mandible. In the harvest sites are the external oblique ridge, your retromolar area, or your symphyseal area. And in both the maxilla or the mandible, you can use a safe scraper to harvest your particulate autogenous bone. So what are the advantages? It's the gold standard, even today. Excellent osteoinductive potential, some osteogenic potential as well. Early turnover, good quality of de novo bone formed, but donor site mobility, extra time and skill sets. Maybe you need an extra armamentarium by way of harvesting equipment, and limited intraoral supply. When you talk of allografts, it's just peel a pack. You buy it, you open the pack, you use it, mostly osteoconductive. A bit longer turnover time, no donor site mobility, no extra time and skill sets, but less osteoinductive potential. They are very expensive when you talk of good allografts, which are US FDA approved. In my practice, I typically use allografts which are only US FDA approved because I have not had very good successful results with some of the local ones available here. When we talk of allografts, there is freeze-dried bone and there is demineralized freeze-dried bone. So let us differentiate. What is the basic concept behind FDB and DFDB? So freeze-dried bone resorbs a bit slower. DFDB resorbs faster. So DFDB contains a little bit of bone morphogenic protein, and DFDB may have some osteoinductive potential as described by Urist in 1960. So the way that they are given to you, DFDB comes more in a putty form, FDB comes more in a particulate form. You may have a mixture of cortical allografts, you may have a mixture of corticocancellous, you may have just pure cancellous. You need to choose what you want. If you use just cortical, the turnover time will obviously be longer. Let's talk about xenogenic bone. Again, peel a pack protocol, pick it up, buy it, peel it, use it, mostly osteoconductive, just acts as a scaffold. Quality of bone is not as good as autogenous, but it hangs around for longer, mostly a scaffold. It's a bit expensive, yes. There is a risk of BSE, but if you use, again, good US FDA approved grafts, like bovine grafts available like BIOS and Geistlich, they are very good, which have very low risk potential. We recently published in the IJPRD, wherein we gave a comparative assessment of bovine versus porcine xenografts. So we compared a typical bovine sintered graft with a porcine graft. Remember, when we talk of xenografts, they can be enzyme treated, like your Geistlich biomaterials are there, or they can be sintered, like a material known as Cerabone, which is there. Sintered means they are heat pressed. They become more compact, they become more dense, they remain for longer, they take much longer to turn over into de novo bone. So if you're typically using a sintered xenograft for a socket graft, it's not a good choice if you ask me. When you talk of carbonate apatite versus hydroxy apatite, the resorbability of carbonate apatite by osteoclasts is higher and faster than sintered hydroxy apatite. So carbonate apatite will turn over faster. It will not hang around that long as a sintered hydroxy apatite. So again, as a clinician, we have to understand where we want to use the graft, what we want to use it for, how fast we want our bone turned over. Are we placing our fixture within 3 or 4 months? Are we placing our fixture after maybe a year and a half or 2 years? And that is what tells you what you should use and what you should not use. You also have alloplasts in the market today. Again, peel a pack protocol, mostly scaffolds, mostly osteoinductive. The quality of bone is not as good. Very short turnover time. They may be available as morsels. They may be available in the putty form. So let's discuss a couple of cases now. Here you see a typical case wherein we place an immediate fixture, type 1 placement protocol. as per Boozer and Chen, when you have to graft the facial. Now, I typically like a slow resolving xenograft at the facial, and we use something called as a mucograft seal available from Geislich to plug the socket. It gives you a beautiful result. Another case of a socket graft, type 1 fixture placement, the tooth comes out. How does your particle size influence the outcome? It influences the adaptability, the retention, the vascularity of the matrix, the injury to the adjacent anatomic structures. It influences your turnover time, and it also influences volume maintenance. So if I'm using particles in a socket graft, I would obviously want to use the smaller particle size. If I'm using particles in the sinus, I would want to use the larger particle size. So this is a very good paper which you can go through, which mentions the influence of particle size and how it has an impact on the outcome. The larger particles are better. For example, when you're talking of sinus grafting, smaller particles are better in horizontal and vertical ridge augmentation. There's definite scientific logic applied to it, again, related to volume maintenance, vascular fill, your adaptability, your handling, and the retention of graft where you place it. So there is something also called as dual layer grafting in aesthetic zone when you talk of type 1 fixture placements. Dual zone grafting means what? You place some biomaterial inside the socket at the facial of your implant, and you place some biomaterial between the periosteum and the cortex. So obviously, the biomaterial which I place in the socket, I want turned over faster. The biomaterial which I place between the periosteum and the cortex, I want it to be slow resolving. So again, we have to apply our science. And you see this case here, you see how beautifully the ridge has been maintained at 4 years. And you can see a wonderful naturally mimicking emergence profile of tooth number 11, which is the maxillary right central incisor. You can also have extraction sockets related to implant extractions. You don't always need to look at teeth to be extracted. You can have fractured implants which need to be extracted. You will have a gross defect over here. So here we use autogenous bone combined with bio-os collagen. We cover it up with the barrier and we get good regeneration. We come back after a couple of months, place our fixture, load our fixture. So whenever I'm using this kind of xenograft and autogenous bone, I try and keep my mix to a 60% of xenogenic bone, 40% of autogenous bone, which gives me enough cellular structure to kickstart the healing process. You can also talk of complex sockets, wherein we use a remote incision to get the little periapical and the tooth out. Here we again use a mixture of xenograft, which is bios particles, small particles, along with your cortical shavings from micros. We have a native collagen barrier, very good bone fill at 5 months, optimal tissue contours at 8 months once we have temporized it, and you see how nicely the tissues are integrated at 2 years. So when we talk of grafting related to implantology, we also have to look at the longevity. This is a boy in his 30s. So we are looking at a longevity, expected longevity of the fixture of somewhere between 20 to 30 years. This is a paper which we published in Cohen, autologous human osteoblast for maxillofacial bone tissue engineering. And this shows you how we can harvest autologous tissue from the posterior iliac crest. Road traffic accident, a young lady lost most of her anterior teeth in the mandible as well as the maxilla. Some of the teeth went impacted because of the trauma. So how do you get from point A to point B? It's almost a knife edge ridge. And at the end of the outcome, we had almost a centimeter of horizontal bone to place our fixtures. So I'll show you a short little clip by way of what we did. This is done under sedation in the operating room. We are taking out marrow from the posterior ileum. It's transported in special kits. So in this 4 ml of solution that they provide us in the automix syringe, we get 60 million osteoblasts. So this is as good as using something like Infuse, which is RHBMP2. It is, I won't deny the fact that it is a bit pricey, but we have our lab in Pune, which does this for us. We have used this in more than 3 or 4 cases with excellent results now. Let's talk about vertical ridge augmentation. An extreme case, this case interestingly was referred to me from all the way from Lucknow, from my alma mater. The lady came to me with the molar present. I told her that we can't salvage the molar, we need to get rid of it. At that point of time, all that it required was a simple soft graft, no fancy stuff. She didn't believe what I told her. She left. She went to some other dentist who just yanked out the molar and left it with no grafting. And this is how she was referred to me. Absolutely no bone. It's a huge vertical defect. And she was interestingly referred to me saying that please go to Dr. Yazid, he'll do a sinus graft for you. So what we need to understand is that we don't need a sinus graft here. If you do a sinus graft, you will be grafting the superior vector and not the inferior vector. What we are missing here is the inferior vector and not the superior vector. So we need to bring the fixture down where it should be from the prosthetic standpoint. We cannot have a 10 millimeter long fixture and a 25 millimeter long crown on that. So we need to graft both the vectors, the superior as well as the inferior, because here again, I used a mixture of cortical shavings and xenograft. I mixed it with some PRF, which acts very well for me over the years. I've been using PRF as a carrier. So it gives me something called a sticky bone. So the graft particles don't flow around all over the place. I can actually layer my grafts for me. And this is how beautifully the bone regenerates. So we convert an FP3 defect into an FP1 defect at the end of a couple of months. This is the amount of bone which has been regenerated. We place our fixture here. And this is a 5-year follow-up. And you can see where we started from. We started from ground zero with nothing but a small little cortex at the palatal. And this is where we are at 5 years. So once again, when we choose our biomaterials correctly, we get a good result. Let's look at some horizontal ridge augmentation. So here, what we see is failing implant, a monocortical implant lying within the casing of the bone. Here again, we use IPRF, we layer our grafts. So on one side, we have a xenograft, on one side, we have the autogenous bone, and that acts beautifully to contain the layers where they are. If we just use and mix the grafts with saline, while you are applying the barrier, while you're closing up, while you're suturing the wound, there is a little bit of intermingling of the layers, which I do not want. I always want my xenograft to be outer. And you see a 7-year beautiful maintenance of the cortical bone. So this is possible only when we have autogenous bone in contact with your fixture and xenogenic bone at the facial contour. The small little clip which shows you how we use alloderm with a tenting screw. So you see, when we use allograft here with PRF, we layer it, we have a beautiful result at 13 years. And these are the scans which will prove to you. So when I do a long-term follow-up, wherever I've grafted, I don't only rely on the clinical picture. Sometimes the clinical picture belies you. So we always get our 3D scans done to see where the facial cortex of the bone is. Here you see good maintenance of bone at 13 years, which is a decent long-term follow-up. Some of us know of the sausage technique given by Esteban Urban. He's a periodontist from Hungary, which is a very popular technique nowadays. A young lady, she's a physiotherapist in the hospital where I work. So she approached me. Now, obviously, when we extract all these teeth and we do extreme amounts of horizontal augmentation, we cannot ask her to walk around with nothing at all. From the aesthetic standpoint, we don't want any removable prosthesis from the standpoint of tissue loading. So therefore, we place temporary implants, we use our mix of micro-cortical shavings and xenograft, and look at the beautiful amount of bone that we have generated. See where we started from. We hardly had about 2 or 2.8 millimeters of horizontal to start with. And at the end, we have about 1.5 centimeters to end with. And this again reminds you that when we have a young patient, we have to over contour our defect because we are looking at overbuilding. We are looking at a long-term result. We are not looking at a result of 10 years. We are looking at a result maybe 20 years and beyond. This picture tells you how sintered hydroxyapatite behaves differently compared to carbonate apatite. So on your left, on your extreme left is carbonate apatite, almost completely turned over into de novo bone. In the middle is enzyme-treated hydroxyapatite, which has decent turnover, but you can still see a bit of the particles hanging around. And on your right is sintered hydroxyapatite, where it is a poor turnover. So you need to decide when to re-enter, depending on what you have picked up as your biomaterial. When you're looking at contour grafting, like a case in this, the fixture is completely within the cortical confines of bone. We're just looking at contour grafting. So I just pick up porcine xenograft, carbonate apatite, optimal contours. Look at where we started from and look at where we ended. So these are the pleasing contours which a patient desires when they come in for an aesthetic zone rehabilitation. Now, does cortical size of defects matter for spontaneous regeneration? What if we place a fixture here and we leave it? We don't put anything at all. Do we need a graft at every point of time? No, we don't. So what is the critical distance, jumping distance? Some say 1.8, some say 1.5. So a good barrier would be 1.8. Anything beyond 1.8, I am always comfortable putting in some biomaterial. But remember, if we leave it as is, the defect morphology plays an important role in deciding whether the bone fill will happen to be optimal or it will not happen. When you talk of block versus particulates for vertical gain, I will always favor blocks. I will show you a couple of cases. Ridge augmentation here, young lady again. We used the block graft for ridge augmentation, but here we used a BioOs collagen xenograft block with micro scraper. You see where we started from. You see where we ended. We have optimal facial contours now. Once the regeneration has happened, we re-enter at stage 2, place our fixture there, close it up. And at 4 years, we have a pleasing outcome with good maintenance of contours. Now we need to ask ourselves, if we had just used alloplast over here, or if we had just used autogenous particulate bone here, would we get this result at 4 years? I don't think so, because the graft shrinks away very fast. So as clinicians, we need to understand what we need to pick up and why we are picking up and what we are picking up for. Let's talk about the sinus. When you talk about decision-making in the sinus, there are a couple of publications. There's a publication which our group gave in 2017, which you can refer to in the JMOS, which technique to use, which biomaterial to pick up. Again, your biomaterial will depend on the technique that you use, whether it's a direct or a lateral window approach, whether it is a crestal approach. So here you see, we use a crestal approach. We used allograft. You see how well the bone has integrated. It's hardly discernible from the autogenous marrow complex. Extreme amounts of vertical ridge augmentation in the posterior, a mix of allograft and xenograft. Some cases where I do not get my autogenous cortical shavings, my first choice for a sinus graft would be autogenous cortical shavings and mix it in a 60-40 with xenograft. My second choice would be to mix it with allograft in certain cases where you don't get autogenous shavings. So you have a good bone fill in such a case as well. The typical case of an eggshell maxilla. Now ask yourself, where is the autogenous bone available in this case? The patient is 70 years plus, she will not allow a second surgical site for autogenous harvest. So here we have very little room for error. So autogenous shavings are not an option here. So here we use demineralized bovine bone along with allograft. And you see the vascularity being preserved here. We use piezo surgery because we want to hang on to every little vessel that we have over here. So the surgical sequence in this would be correction of the vertical deficit by way of lateral window sinus graft, thereafter correction of the horizontal deficit. You adapt your barrier because it's particulate graft, you don't have to adapt the barrier, and tension-free passive wound closure. So look at where we started and look at where we have ended. So we've gained both the horizontal component in an optimal vector and the vertical component in an optimal vector. And this is what we want to see when we re-enter after a couple of months to place our fixtures. We want to see good vascularity. We want to see bleeding bone when we perform our osteotomy. We don't want to see graft particles hanging around there. A small little clip which will show you a sinus graft.
I'm don't worry, go taking home and that's like right.
Of course, Dada. The Superman. Job में कोई भी प्रॉब्लम होती है आगे पाँच हजार और है तभी से सारी प्रॉब्लम से करते हैं इनफैक्ट जहाँ तुम्हारी प्रॉब्लम वो पहले पड़ती है राइट
I would like to request all the participants to kindly mute yourself.
Thank you.
So this is where we started from and this is where we ended. So here you saw a technique by way of which we mixed the xenograft with the allograft in a little peculiar way. So why? Because I want a core of allograft for better bone implant contact, and I want a peripheral shell of the xenograft because that is what is going to maintain my volume long term. So typical pointers for predictable results. When you want pointers for predictable results, you have to ask yourself, mesenchymal stem cell recruitment is what kickstarts your turnover of the biomaterial that you have used. Is there adequate vascularity at the place where I'm placing my graft? If you give me D1 bone, like the anterior mandible, and you say that there is a thick cortex, and please use an alloplast. Obviously, I'm not crazy that I'm going to pick up an alloplast and I'm going to use it there. I would much rather use a complete component of autogenous bone over there. I would have to do something by way of cortical perforations to get out the cancellous vascularity. That is where the turnover of your biomaterial is going to happen. Then what is the stability of your graft? We all understand from our days of dentistry that micromotion favors fibrous tissue formation and absolute immobility favors osseous tissue formation. So whenever we place a particulate graft, or even if we are placing a block, why do we say that when you're placing a corticocancellous block or a xenograft block, try and adhere to the minimum 2-screw fixation rule? Because we don't want rotational movement. Why do we say that when we use a sausage technique with a barrier, please tack the membrane all around, use as many bone stabilizing pins as you can so that there is no micromotion. We have to ensure passive closure. We cannot have closure under tension. If we close under tension, I'm sure you will be able to close your flap. But day 3, and boom, the whole flap undergoes dehiscence, you lose part of your biomaterial. What would your optimal re-entry time be? Now, in this sinus case, the video that you just saw, my optimal re-entry time was at 6 to 7 months. Why? Because the core was allograft, which has a relatively faster turnover time, whereas the peripheral shell is the xenograft. So I'm not concerned whether the xenograft is completely turned over or it is not turned over. I am concerned with what has turned over, which is in direct contact with my fixtures, with my implants. Pertinent questions which we need to ask ourselves. What is the basic role being played by the biomaterial that we are using? Is it just a scaffold? Is it going to attract the stem cells? Is it actually going to recruit osteoblasts? What is the comparative ease of handling of a graft? Is there a bone which has been contained, and when you open the packet, is it available in a sticky format so that it doesn't fall around, you don't end up wasting particles? What is the fate of the biomaterial with time? If I return to that site maybe 10 years down the line to place an implant in an adjacent tooth, will I still see part of the biomaterial hanging around, or will it completely have turned into de novo bone? Will I see shrinkage of facial contours, or will the facial contours be maintained with time? What is the comparative turnover of different materials when we are mixing and matching those materials? And that's exactly why I told you that I want to, and I like to layer my particular grafts wherein I have an inside layer of autogenous or allogenic bone and an outside layer of xenogenic bone, which will give you your volume maintenance. So is there a clinical benefit to placing an implant in a site with significantly more vital bone? Obviously. How much vital bone is needed to support a dental implant during integration? This is a multi-million-dollar question, which has no definitive research till date. But I would say, given the fact that you have about 45 to 55% of vital bone, you are good to proceed, because the primary stability is what holds your fixture the day you insert it. And the secondary stability is by way of the biological turnover, by way of osseointegration, which kickstarts after that day. Are there certain biomaterials which will make your osteotomy techniques a bit different? Yes. So whenever we use xenografts, osteodensification should not be used. Why? Because osteodensification principally relies on the cancellous marrow component, and it functions by way of cancellous compaction. And the cancellous marrow component is what provides plasticity to your bone, which works with OD, and that is absent in xenografts. So we should stay away from using osteodensification if we have grafted only using xenografts. What is the difference in percentage of vital bone formed? Say you're using just alloplasts. there will be a very low percentage of vital bone formed. If you're using 60% of autogenous bone and 40% of maybe allograft or xenograft, there'll be a much better percent of vital bone formed. And ongoing research on all these topics will continuously continue to enlighten us. And we share all our work on social media. You can follow us on social media. You can call us and speak to us. And thank you again to all my seniors, all my mentors for giving me this choice and allowing me to present my work here. Thank you so much.
Thank you so much. It's such a wonderful presentation, sir. Now I would like to invite our panelist, Dr. B. Rajkumar, sir, to ask a question.
Dr. Azad.
Hi, sir. How are you?
Fine, good. Yeah. How are you?
Fine, thank you.
That's right. And it was an excellent presentation, and just you have made it very simple for people to understand. Not much of complications in this. I just wanted to ask you one or two things in this.
Yes.
How do you really prefer ridge split technique, or you don't go for it?
So ridge split typically has a very limited role to play, wherein you have to have the correct morphology of the ridge. A thin ridge, which is a parallel morphology ridge, is not a good ridge to split. It has to be triangular in shape. You have to have a minimum of 3 millimeters of cancellous bone, because the elasticity of the cancellous bone is what allows you to move the split apart. Because if it's purely cortical bone, you will have bone flaking apart. So you'll end up getting a Khuri graft. Okay. So I do use ridge splits, and the predictability of the bone formed in ridge splits is far superior to using a block graft. But then again, you have to have the ideal case wherein you can use a ridge split.
And we were talking about grafts as allografts, autologous materials, like we use a tooth, extracted tooth as in powdered and so
Yes.
on. What do you expect? What do you think on those lines?
So we have used that, but I will tell you one thing, that acts basically as a scaffold, number one. Okay. And there are maybe 5 to 7 year histological follow-ups which have very clearly shown that the dentinal particles which have been ground down, even after a period of 5 to 7 years, they still have been hanging around over there. They have not turned into de novo bone. So they provide you with a scaffold, number one. Number two, there is a little bit of a myth in the market when you talk of a tooth bone graft, saying that it's a free bone graft. It's not free by any means. The armamentarium costs a bomb, number one. Number two, there are certain decalcification processes which need to be done. You need to decalcify the tooth prior to grinding it. It's a bit time consuming. You need a second pair of hands in your operatory. And there have been materials like xenografts which have been working very well in my hands over more than 17 years. So I have not used too much of tooth bone, although I have used it in maybe 2 or 3 cases of mine.
The reason is because since you have been using multiple bone grafts going on, and so I was just thinking, because I had one equipment of this as a tooth transformer here.
Correct.
And I have been trying to use this for some time. I just wanted to know, get your opinion on this. How good is it, or how safe is it to go along with it? So
yes.
I just wanted to clear my doubt on this. And then one more small thing is that I wanted this. Could you just tell me about this Khuri technique? And this guy is a French guy. Am I right?
Yes. So Khuri technique basically is where you have a bone plate, an autologous cortical bone plate, which is fixated at a given distance. So say you want to regenerate maybe 8 millimeters of horizontal component of bone. So you take an autologous cortical plate, you fix it with monocortical screws to the native bone, and you keep it at 8 or 9 millimeters away. You take good amount of autogenous cancellous marrow and you place it in between the native bone and that plate, and you cover it up. So that forms a good block of bone at the end of it. But nowadays, you also get, there's a company by the name of Botis, which also provides xenogenic plates for the Khuri technique.
Okay. Thank you, Doc. Excellent. And is there any other questions from the audience, please? Okay then.
Thank you so much, sir, for all the questions and answers. Now I would like to invite Dr. D.N. Kapoor, sir, to add few words. Now I would like to invite Dr. D.N. Kapoor, sir, to say a few words.
I think Dane sir is on mute.
Yeah.
Hello,
Yeah, sir.
Hear you, sir.
am I audible?
Yes, sir.
Yeah, sir, you are
Oh, I'm
audible.
sorry. Yeah. Dr. Gandhi, you have covered very well good topic today for the opening, and you have discussed in detail the biomaterials used, and I am sure people will be beneficiary in selecting the material for the success of the implant. Dr. Rajkumar has opened few questions and you have very well clarified. I now open with request Dr. Azad to say a few words.
Thank you, sir.
Thank you, Dean. Firstly, I'd like to congratulate Dr. Gandhi for an excellent presentation. And he has clarified many points and has also explained where to use, what to use, and which material is more suitable in which conditions. So it is up to the individuals, how you adopt your technique and how you do it. One thing which I like to say, I've been using the allografts and all, lot of PRF, and that has given me very, very good results in bone augmentation in all conditions. So that you can think as an option, and it provides a good stability to the neck and healing process in the bone formation is very, very good. So thanks a lot. That's what I have to say. Thank you very much to the organizers for an excellent for this webinar. And
Thank you, sir.
Thank you.
Thank you so much, Dr. Mahendra Azad, sir, and Dr. D.N. Kapoor, sir. Now I would like to invite Dr. Anmol Bagaria, ma'am, to end the session.
I would like to thank Dr. Mahendra Azad, sir, the chief guest of this webinar, for his gracious presence. I would like to thank the panelists for today for giving their valuable time. I would thank Dr. B. Rajkumar, sir, for his valuable time. I would thank Gandhi, sir, for such an amazingly informative session. And I would also thank the Master of Ceremony, Dr. Misbah, Dr. Nitin, and the co-convener, Dr. Sarviraj Kohli, sir, for his time.